Good morning. Today we are going to review rapidly how to measure the blood pressure using a mercury sphygmomanometer. When you use a mercury sphygmomanometer, like the traditional one, you have to use the stethoscope together with the sphygmomanometer. Let's first see what the mercury sphygmomanometer consists of. First of all, this is the device, and there is like a metallic button here, and you compress this metallic button in order to open the device. When you open the device, you will see the following pieces inside. First of all, you have this reservoir of mercury, this glass reservoir of mercury that contains the mercury that is inside the sphygmomanometer. Actually, if you look at that reservoir, it is continuous in a U-shaped manner with this glass column. Now, in this glass column, you cannot see any mercury. You cannot see any column of mercury just because this valve is closed. We usually close this valve after having finished the measurement of the blood pressure in order to avoid entry of air bubbles. If you leave that reservoir open, that valve open, and the mercury in the reservoir will equalize the height with the mercury in this glass column. So you will see some mercury at the bottom if this valve is left open after you finish measurement of the blood pressure. In such a condition, if you don't close the valve, and if mercury is left here or part of the mercury is left freely here, whenever you close the device and you move it either horizontally or vertically, then air bubbles might enter and interfere later on with your future measurements of the blood pressures. So one of the major precautions is to close that valve whenever you finish measurement of the blood pressure. Once you open that valve, you will see, once you open it like this, you turn it like this, as I did. This is closure of the valve. This is opening of the valve. Once you open the valve, you will see a very small column or a very short column of mercury that is almost invisible here on the screen because it is very short. You will be able to see it when mercury rises in the this glass column. This bulb that contains the mercury inside forms a U-shaped structure with that glass column. So it looks like a manometer. A manometer in physics is a U-shaped device that is used in order to measure the blood pressure. And at any time when you use this rubber, this rubber piece in order to inflate, you will see that you are adding pressure to the mercury. And when you add pressure to the mercury here in this reservoir, this will be translated as a rise in the height of the mercury column here, because the pressure of mercury in both arms of the U-shaped manometer should be equal. And the height of mercury in the glass of column at any time will be representative of the pressure of mercury, which is the same as the pressure in this glass reservoir and the same as the pressure you are applying through this rubber piece to the cuff that we inflate around the arm. Maybe it's difficult to imagine that this is a U-shaped glass tube because this side or this arm of the U-shaped manometer or glass tube is covered by that black cover, and therefore it's hard to imagine that this is a manometer. So actually, when you are, here there is another valve here in this rubber piece that you hold in your arm. This is like a rubber balloon that you hold in the palm of your hand, and you have to close the valve here, because if you don't close the valve and you try to inflate, it will not transmit the pressure. So after having made sure that the valve here is open and that your mercury manometer is put horizontally on a table at the same level as the heart of the patient, I'm just lifting it up in order to allow you to see the whole device, but it has to be put at the same level as the heart. So if my heart is at that level, then this has to be, this part of the mercury device has to be put at the same level on the table, at the same level of my heart. This allows better representation of the pressure in the left ventricle. That is the pressure in the aorta. That is the arterial systemic pressure that we need to measure. If you put the device a bit higher, then the effect of gravity will be shown on your blood pressure, and or even if you put it lower than the level of the heart. So it has to be at the same level of the heart to be almost equal as the pressure in your heart and in your aorta. So we have talked about two precautions. The first one is the closure and opening of that valve. The second one is putting it on a horizontal level. The third one is that it has to be at the same level as your heart or the heart of the patient. And the fourth precaution is that before trying to inflate that balloon, you have to close the valve. So what do we do when we try to compress that rubber balloon after having closed the valve? That rubber balloon is connected through a rubber tube to this piece we call the cuff, okay? And you have to make sure that this cuff that is connected to, you see, it is connected to the sphygmomanometer. It is connected to the sphygmomanometer. So you have to make sure that this cuff is completely intact and that the rubber tubes that are connecting the rubber balloon to the cuff are perfectly sealed and are intact. And sometimes on the long run, this rubber band or rubber tube can get damaged. So if there is any kind of tear or damage here in the rubber tube, then this would result in leakage of air outside this would result in leakage of air outside and false results. Inside this bandage, okay, you have to, first of all, you have to rotate that or like put that bandage around the left arm, okay? Better than around the right arm, because the left arm is a better representative of the systemic arterial pressure, because the heart, the aorta is, the arch of the aorta is like towards the left side more than towards the right side. And then the cuff has to be of a proper size, meaning that when you try to rotate the cuff or wrap the cuff around your arm or the arm of the patient, this shouldn't be too tight, neither too tight nor too loose, meaning that it has to be of a proper size for the arm of the patient. Now, I'm doing this now because I'm going to rotate it around my arm, which is a rather difficult process to do it to myself. So I'll try to make the wrap first and then put it around my arm. Of course, around the arm, not around the forearm. For obese persons who have very thick biceps muscles, or where the arm has a big diameter, you have to use bigger cuffs. And when here there is a rough tissue that makes the two ends stick together or fit together. And then here, when you put it around the arm of the patient and you start tightening it like this, it has to be neither too loose nor too tight, okay? Taban, I can do it perfectly for myself. Here, for example, it's too loose, see? Yani it can accommodate my fingers and at the same time have more space. No, it has to just be able to accommodate your fingers or accommodate the stethoscope. Now, concerning the stethoscope, Taban, this is the way you are going to listen to the sounds here. So you put the earpieces in your ears, and then here you have two sides for the stethoscope. You have the diaphragm, which is the flat surface, and you have the bell. Now, in my stethoscope, this is a Littmann one that doesn't have a bell here. But even if you have a bell here, then you have to use this side, which is the diaphragm. So how can you know that it's not too tight? It has to allow the diaphragm of the stethoscope to be put with ease under the cuff of the sphygmomanometer. Here we have two arrows, okay? We have two arrows here. The first one is an arrow for a descending arrow for the left arm, and another one is a descending arrow for the right arm. Since you are rotating it or fixing it around the left arm, then you have to make sure that this arrow that you can see here is fitting with the brachial artery. Now, how can I know the site of the brachial artery? First of all, you're going to put the palm of your hand on the antecubital fossa that is opposite to the elbow, okay? And you will try to flex your forearm. When you flex your forearm, you will feel like a thick, firm cord under the palm of your hand that is moving as you flex your arm and extend it. This thick cord is the tendon of the biceps muscle. This is my biceps tendon. So with my index finger and my third finger, I will, first of all, put them on the bicipital tendon, and then I'll move 2 centimeters medial towards my body. As I move medial, I find here like a groove, like a depression, okay? This is where you can find the brachial artery. Now, where exactly along that groove? 2 centimeters above the antecubital fossa. So if this is the line that represents the antecubital fossa, then you go 2 to 3 centimeters upwards. After having moved medially 2 centimeters from the bicipital tendon, and you put your 2 fingers and palpate. When you palpate, don't compress strongly, because if you compress strongly, you will close the brachial artery and you will not feel any pulsation. Why are we trying to find out the brachial artery? Because this is where we are going to put or place the diaphragm of our stethoscope under the cuff of the sphygmomanometer. I can do both actions for myself, as of course, as a medical doctor or a medical student, you can do it for your patient. So we don't place the stethoscope anywhere, we put it in a particular location, which is that of the brachial artery. And this is where we are going to hear the sounds that are called Korotkoff sounds, and these will help us determine the value of the systolic blood pressure and the diastolic blood pressure. Why have we selected the brachial artery to place the diaphragm of the stethoscope on? Why didn't we use, for example, the radial artery? This is because the brachial artery is closer to the aorta, and therefore the pressure in the brachial artery is more representative of the real arterial blood pressure than the radial artery. The brachial artery is a bit smaller, or significantly actually smaller than the aorta, but it is one of the large arteries in the body, and it is one of the closest arteries to the aorta. It's actually one of the branches of the aorta, or an extension of one of the direct branches of the aorta. Okay. Now, after having placed everything in place, we're going to start inflating the cuff. When you start inflating the cuff, you will notice that you are increasing here. I turned off the valve, or I closed the valve, and I start inflating. When you start inflating, you have to do this very rapidly and very sharply. So as you are doing this, I don't know whether you can see the column of mercury or not. See how the mercury of column is, yes, I can see it on the screen. So we are going to elevate, to inflate like this with sharp movements until you reach 30 millimeters mercury above the expected systolic pressure. For example, if my expected systolic pressure is 120, then I'm going to raise it until I reach 160 millimeters mercury or 150 millimeters mercury. See, every time I inflate here, the column of mercury is rising in the glass tube. Okay, and here we have to say something very important. We said that we have to inflate to apply pressure here until we reach a reading that is 30 millimeters above the expected systolic pressure. How can I guess the expected systolic pressure? Classically, we have to use what we call the palpation method, meaning that in the palpation method, I'm going to use the sphygmomanometer. I'm going to use the sphygmomanometer, and meanwhile, I'm going to feel or try to feel the radial pulse here. How can I feel the radial pulse? Again, using my index finger and my third finger. Here is the radius, the bone. Here is the bone that is towards the thumb. We call it the radial bone. Here on this aspect of the forearm, if you use your two index fingers and go past the bone and go between the bone and the first tendon you meet, the first cord you meet here, you will find again a depression. And if you press a little bit downward and a little bit towards the bone, but not too much pressure, you don't apply too much pressure in order not to close the artery, then you will feel the radial pulse. Of course, you know that if we apply pressure here that is higher than the systolic pressure, then all arteries, not only the brachial artery, all arteries will be, the blood will not pass in the forearm, because if you close the brachial artery by applying pressure in this cuff that is higher than the maximum systolic pressure in the brachial artery, let it be 120. If you apply 150, then the brachial artery would be closed, would become closed. And if the brachial artery becomes closed and no blood flow occurs through the brachial artery, then no blood flow will occur through the radial artery. So you're going to inflate this, and in the palpation method, because I didn't mention this in class, in the palpation method, you keep inflating that balloon while meanwhile with the other hand, and if you inflate with your right hand, then you use your left hand to feel the radial pulse. But you have to feel it on the same side, and you have to feel it on the left arm, because if you close here, then it is that radial artery that will be closed, not that one. You will be inflating here until you no more feel the radial pulse, which means that previously you used to feel it before increasing the pressure. And then when you no more feel the radial pulse, just look at this mercury column and see where mercury is. So if mercury is for example, the level of the height of the mercury column is at 120, then the systolic pressure is almost 120. So you did that palpation method without using the stethoscope, just by putting or applying the cuff around your arm and feeling the radial pulse and inflating until the radial pulse is no more felt. After having had a preliminary idea of the systolic blood pressure, you are going to repeat the whole process, but this time using the stethoscope. And this time you're going to, of course, you have to deflate first until the mercury column returns to 0. And then you will repeat the same process, inflating the cuff, watching the mercury column rising upwards. But this time you will not stop at 120. You will move upward until, or you inflate until the mercury column reaches 150. And then you will start to deflate from here. You will start, if you inflate before inflation, you have to turn it clockwise. When you want to deflate, and when you deflate, you open the valve anti-clockwise, so air will be dissipated and the cuff or pressure in the cuff will diminish, and this will be translated as a lowering of the mercury column. So starting 150, you will lower down or the level of the mercury. And for example, let me show you on the screen. Now I'll first inflate until I reach 150. I have to apply sharp pressures on the cuff, and now I reached 160, and then I'm going to deflate and deflate slowly like this. See how the mercury is going downward. So while you are deflating, you will not hear any sound from 150 to 120 because you are much higher than the expected maximum systolic pressure, and the artery is totally closed, the brachial artery, so no sound is heard. As you descend from 120 to 80, which is the expected diastolic pressure, you start hearing sounds because the artery is partially open, and there is turbulent blood flow, and therefore you start hearing Korotkoff sounds. When you reach the diastolic pressure, meaning that when you deflate until the pressure in the cuff is 75, for example, just 5 millimeters lower than your 80, supposing, Taban, of course, that your diastolic pressure is 80, then the artery will be completely open because the external pressure in the cuff is now lower than the internal pressure. When the artery is totally open, then the blood flow is no more turbulent, the blood flow is smooth, and you no more hear Korotkoff sounds. The last point I want to clarify is, why do we go 30 or 40 millimeters above the expected systolic pressure? We do this because sometimes, especially when the patient is hypertensive due to atherosclerosis, for example, there is what we call the auscultation gap or auscultatory gap. What is the auscultatory gap? It means that maybe the blood pressure of the patient is 150, okay? So when you inflate the cuff until you reach 150, you will hear Korotkoff sound. And then when you deflate, you start deflating, and the mercury column starts dropping or moving down in the glass column. You will hear no sound until you reach 120 and you start hearing Korotkoff sounds again. This means that the systolic pressure of the patient is 150, but for reasons that are difficult to explain, in between 150, which is the actual systolic pressure, and when you really heard Korotkoff sounds, in between 150 and 120, when you started rehearing auscultation sounds or Korotkoff sounds, there were no sounds at all. This doesn't mean that the systolic pressure of the patient is 120, but it means that the systolic pressure of the patient is 150, but there is a gap. A gap of what? A gap of the sound. You cannot hear the sound between 150 which is the true reading of the systolic pressure, and 120, which is the value at which you resume hearing the Korot cough sounds. This is called the auscultation gap. And because of this auscultation gap, every time you measure the blood pressure for a patient, you have to rise or make the mercury column rise above the expected systolic pressure by 30 millimeters mercury. Thank you so much. I hope this video was useful.